Myocarditis. When I was started my career in medicine, we had some studies. The first trial was a trial with immunosuppressants. So myocarditis we're going to learn about is inflammation of the muscle cells. And it can be a very benign process or it can be a very serious process. And I'll recall that there was a young individual in their 20s who came in with after a virus. And at that time, it was something called Coxsackie B virus. And he progressed very rapidly and died very quickly. So that was a very severe case, but I've seen many cases, and most of them very, very mild in my lifetime. I've learned how to recognize better. And so I'm really pleased that the team has put together this very important presentation, myocarditis. Let's take away. What's the next slide? And I think Enya is going to start off with fire away.
Yep, so before getting started, let's take a look at the anatomy of the heart and the parts we're interested in today. So the myocardium is in between the epicardium and the endocardium. It is the muscle of the heart and it's responsible for contracting and releasing to help keep the heart pumping blood around the body. However, when one develops myocarditis, the heart muscle is weakened and is unable to help pump blood efficiently. So that's going to be corresponding to the picture on the far right.
So as Anya mentioned with the different layers, you can also see it under the microscope with a stain called H&E. So this is referred to...
Backtrack one slide. Let's show those layers a little bit more. So
Sure.
there are three layers of the heart. It's something called the myocardium, that thick part that we have in the middle. And then we have this one layer of thickness called the endocardium in that darker red. That's one layer thick, and that's where protection in the vessels we see, and the epicardial is the layer furthest away from the heart. So we have this thick muscle layer called the myocardium. We have the outside layer called the epicardium, and then you have the inside part of the heart called the endothelial level. So the heart is like other organ systems, a very complex organ system. You think of, you have this device that's going to pump 60 times a minute on average for the rest of your life. It can go down, it can speed up. Truly amazing engineering. My son's in engineering, and they can't figure out how to make a better heart than the one we have. So words of wisdom, take care of the heart that you have. Next slide, please. Let's show some histology here and what happens when we have inflammation of that middle layer called the myocarditis layer. Go ahead there.
Yes, exactly. As Dr. Curnew mentioned, right now we're in the thick layer called the myocardium. So here under the microscope with the stain, as I mentioned, called the H&E stain, we can appreciate the individual cardiac muscle and also the muscle tissue. So on your right side of the screen, you see the normal myocardium. And those fibers that you see, those are all the cardiomyocytes. The little circular things that look more purplish, that's the nuclei of these fibers. You might be able to appreciate some different lines, like some vertical lines. Those are actually called the intercalated discs, and they help the muscles of the heart contract all together instead of each cell contracting together. So we want to make sure that your heart is pumping all together rather than each part at a different time. Now, on the left side, we can see a classical presentation of myocarditis. So in this case, it's a fairly severe case. You can see that you don't see as much and as well-defined cardiac tissue. Instead, you see these little cellular things that look very purplish. Those are all called neutrophils, which is a type of inflammatory and immune cell that comes in when there is inflammation. So right now you can see that instead of having these nice purple and pink fibers, instead you have these highly cellular things in the middle of these fibers. And that's, again, those immune cells coming to the site of inflammation.
Well, it's kind of interesting if you just go backtrack on the far right, nice pink, normal contracting myocytes. And then on the left, you can see this terrible storm of inflammation going on, destruction. These neutrophils, these cells that fight infection or some can attack the body itself, are basically attacking our own muscle cells. So great slide. Thanks for sharing that. Next slide.
So now we were discussing myocarditis, but a related thing that oftentimes some people mention is pericarditis. Now, in this webinar, we won't be getting into much details regarding pericarditis. But now that we're on the histology section, just so you guys can appreciate the pericardium versus the myocardium versus the endocardium. Here, what you can see, we'll start with the normal pericardium first. So on your right side, near the top of the slide here, near the top right, that's the pericardium right there. And the pericardium is a bit more superficial and a bit more on kind of like near the surface of the heart. So we're kind of moving a bit towards the surface of the heart. You can see how nice and smooth it is. And there's nothing sticking out. It seems the borders seem well defined. You can see the nuclei of the cells, those little circular things that we mentioned. You can also see the myocardium here that looks fairly normal. You can also see the endocardium in the bottom left-hand side of that slide. Now, if we direct our attention to the pericardium, this is constrictive pericarditis. So what that means is there is no nice smooth border anymore. You see these little strands, they're called fibrin. So they're extending into the potential space, and it makes the heart kind of contract a bit less. It doesn't let your heart expand as well. It doesn't let your heart beat as well. So that's just something that you can appreciate with pericarditis. Instead of affecting that middle layer, it's mostly that more external layer. So in this case, again, you see these fibrin strands extending into the pericardium. But again, the focus of this webinar will be mostly on myocarditis that we discussed on the previous slide.
To think about this, myocarditis is inflammation or potentially destruction of the muscle itself. Pericarditis is the heart's in a sac, and it's a sac that protects the heart. It's outside of the heart. And that's what you're seeing over here. So sometimes you can have a process called myopericarditis. So it's affecting both the heart muscle and the lining of the heart called the pericardium. So and so we'll spend a lot more time in the future talking about pericarditis, but I just want to show you those terms. So again, myocarditis is inflammation of the muscle itself, and pericarditis is inflammation of the sac encasing the heart.
Awesome. So, just a little bit on how myocarditis is characterized. As mentioned earlier, myocarditis is the inflammation of that the muscle of the heart. You know, the one that's responsible for pumping, you know, that blood. And so inflammation causes a reduced ability of the heart to pump and can cause rapid or abnormal heart rhythms, and we refer to those as arrhythmias. Inflammation can enlarge and weaken the heart, create scar tissue, and this ultimately forces the heart to work harder to circulate blood and oxygen throughout the body. And so here is just like an ECG chart, or an ECG of a heart with myocardia and one of a normal heart. So the most common ECG abnormalities seen in myocarditis are sinus tachycardia and non-specific ST segment and T waves change. So here on the left side, we can see an example of that, an ECG of sinus tachycardia with non-specific ST segment changes. And next slide, please.
So it's kind of interesting. So you can see that the heart, we can see a simple thing, a cardiogram can give us some clues about the heart. So we also can look at other tests as well. So the first step is that if you think something's wrong with your heart, you're having chest pains that you're worried about, getting an ECG would be something to think about. And obviously most emergency rooms can do that. Most doctors' offices can't do that. people who go to heart doctors, they can do that. So so that's and on the right you can see a nice normal beating heart. On the far left you see a heart that's just beating too fast and has some very mild changes there. Thank you for sharing that. Next slide, please. Go ahead.
All right, so let's take a look at some mechanism causing that inflammation. So some causes of myocarditis include viral infection, which is the leading cause actually, and this includes the virus that causes common cold, which is adenovirus, hepatitis B and C, and there are a couple more as well. But just for sake of time, we're moving on. So some other factors include bacterial infections, exposure to environmental toxins such as snake venom or poison from metals, and parasites. Individuals who have an autoimmune disease that causes inflammation, such as lupus or rheumatoid arthritis, are also susceptible to myocarditis. But the link between the link between all these potential causes is that inflammation occurs during the course of infection, and this puts stress on the heart that remains even after the infection resolves sometimes. Though there are many potential causes, the risk of actually developing myocarditis is very rare.
So it's kind of interesting, if you just backtrack that slide there, is that we know that inflammation of the heart, myocarditis is common, or I wouldn't say common, but it's well known. It's been around for a long time, and many viruses cause a mild form, and sometimes it can lead to a very severe form. And autoimmune just means that your body's attacking itself. Somehow is that the body's being fooled that what your normal cells are considered foreign, and foreign cells are basically attacked by your immune system. Remember that first slide at the beginning where you saw all those bluish inflammatory cells attacking your normal heart muscles? So there could be different triggers on that. And a lot of times we don't fully understand these processes, but one of the things is to sometimes just calm inflammation. That's why things like, you'll hear medications like steroids, prednisone, cyclosporin, and other immune suppressing agents can calm the immune system when it's overactive. Thanks for sharing that. Next slide, please.
All right, and here are just some symptoms that I've listed down here. So some of the mild symptoms include chest pain, rapid or irregular heartbeats, shortness of breath, swelling of hands, legs, ankles, and feet. And sometimes in the early stages, some individuals don't show any symptoms at all. But in some severe cases of myocarditis, the weakening of the heart makes it so that the rest of the body doesn't get enough blood, and clots can form in the heart, leading to a stroke or heart attack. But I also have to note that these are very, very rare occurrences as well. Yeah.
So it's kind of interesting if you go back to chest pain. So not every chest pain is bad. Is that so? If you're having a heart attack, that's more of a heaviness that sits on my chest. It's not a pain doctor. It's a weight, the heaviness. I feel sweaty, feeling unwell. That's pain that can be consistent with having a heart attack or angina. Especially angina happens when you're walking. I get this tightness in my chest when I'm walking. I have to stop and rest. The pain lasts between 30 seconds and a few minutes. Better with nitroglycerin. That's classic angina. We mentioned things like pericarditis. Well, pericarditis is inflammation of the lining of the heart, the sac of the heart. That's usually a sharp pain. When I cough, I move, I get this sharp pain. That's classic for pericarditis. So the type of pain, so I always describe the pain. Look, if you had this pain in your chest for the last 50 years, it hasn't changed, you know what? You're probably okay. Other pains, indigestion, after certain foods, I get this sour taste in my mouth, and I felt this feeling uncomfortable in my chest, and it feels better after I belch or I take antacids. It's gastric reflux pain. I fell and banged my chest. I had this sharp pain. I press on my chest wall, it hurts. That's usually musculoskeletal type pain. So, always learn to describe the pain well in the circumstance. And anybody over the age of 50 years of age should probably have an ache and pain most days. Every day I wake up with an ache and pain. That means I'm human, I'm alive. So it's always sort out the pains that are serious pains and pains that are not. So thanks for sharing that. Next slide, please.
Awesome. And so here's just a case study. In a Polish study, the researchers compiled data from the National Health Fund, which is the only public healthcare insurer in Poland. And they collected data over a period of 10 years from January 2011 to December 2019. And during this period, they found that 19,978 patients were hospitalized due to myocarditis, with 74% of that population being male. And the incidence of myocarditis was highest in patients aged 16 to 20 years, with the proportion of female to males tended to increase with age and was the highest in the oldest age group. So as patients got older, more females were affected than males. So the next slide is just a graph summarizing kind of their findings. And so during that 10-year observation period, myocarditis occurred in patients of all ages with clear predominance in patients aged 16 to 30 years old. So it's relatively young, and they typically had a higher proportion of male patients were affected. However, as I stated earlier, as the population got older, more females were affected than males. As you see here, in 81 plus years old in that kind of section, a bit more females were affected than males. And furthermore, during a 5-year follow-up, 6% of all patients, 3.7% of males and 6.9% of 3.7% of females and 6.9% of males were rehospitalized for myocarditis. And so, in conclusion, just like the study observed that myocarditis affected relatively young individuals and so forth. Just like a little separate there.
And most cases of myocarditis are pretty benign and pretty mild, okay? So, and these are the ones that we've detected. Thanks. Go ahead.
Matthew, is anyone taking on this section?
This is viruses, bacteria, fungal, and parasites here.
I'm not sure actually who's taking this section.
Okay, so let me give it a go over here. So we have different causes of infections in the heart. You can see that traditionally Coxsackie, V virus, adenoviruses, different viruses can affect the heart. You can see that parts of the world parasites can affect the heart. Fungal infections, other parts of our Chagas disease is common. It's certainly not common in North America. We can have bacterial infections, and if you have a bacterial infection, that's more of a very serious form. So most of the viruses are self-limiting. Well, I came from Connecticut, where I did my internship at one of the Yale hospitals, and Lyme, Connecticut was relatively new disease at that time. Was discovered as a different form of parasitic infection and things of that nature. So you can see that. So the common cold can cause a virus to the heart, and serious bacterial infections can cause a problem too as well. So lots of etiologies, lots of causes, and many times we don't actually find the causes. Next slide, please.
Yeah.
And,
so.
Go ahead.
Yeah, so in terms of, I guess, the viruses, bacteria, and fungi, as mentioned before, viral infection is actually the most common cause of myocarditis and accounts for almost all of the cases, 10 to 22 per 100,000 individuals. So still relatively, myocarditis isn't the most common effect, but it is associated with some viral activity, as you can see here on the slide. Another cause of myocarditis could be medications, so certain cancer treatments or heart medications and antibiotics as well, antidepressants, anti-seizure, and some kidney medications. These can all lead to some of those inflammatory responses we're seeing and lead to that myocarditis. Again, depending on the severity, most myocarditis tends to be relatively mild or benign in nature. And
It's kind of
lastly,
interesting.
oh,
If you
go
just
ahead.
go back one slide there. One of the things is that there's new immune modulating drugs in cancer called checkpoint inhibitors. And they've become a new cause of they can cause skin reactions, and they can actually affect the heart muscle too as well. So we're learning all the time. And so is that really impressive right now is how fast medical science has evolved right now. So truly amazing. Next slide, please. Go ahead.
Yeah, and I guess the last one is the just some illicit drug use. So things like cocaine can be very much associated with cardiomyopathy as well as myocarditis. So obviously, as you can see from this quote here, cocaine can have some severe effects on the heart that can be very detrimental to one's health.
And I've had a personal experience with lots of patients affected by cocaine. Cocaine is a potentially very dangerous drug. So if you have an issue with cocaine, seek help. Talk to your physicians. We can there's strategies to deal with this. And having cocaine-induced heart damage or deaths is a terrible thing. And depending how you use the cocaine, obviously intravenous drugs can affect the heart too as well. But cocaine can just induce just a surge of the adrenaline type system, and so very serious consequences. So be careful.
All right, so now that we've looked at the ways that myocarditis can be caused, we can take a look at how your doctor might diagnose myocarditis. So diagnosis starts first with suspicion of myocarditis, and some reasons why you might be suspicious of myocarditis or any other heart disease is that you might have signs and symptoms, including chest pain, difficulty breathing, or palpitations. Your doctor might also notice abnormal changes on your ECG, as we've looked at before, or you and your doctor might notice elevated levels of certain biomarkers in the blood, such as C-reactive protein or troponin T or troponin I. And C-reactive protein basically indicates inflammation, and as Enya talked about, myocarditis is an inflammation of the heart muscle, and troponin T and troponin I are indicators of heart damage. So
Let's go backtrack one slide again. So one
Yeah.
important things to think about is your symptoms and are important. But one of the things that we measure right now is something called troponin. Troponin is found predominantly in the heart. And it basically, if there's been heart damage, so if you picture that slide there with the inflammation, all those inflammatory neutrophils in that, is that it's actually causing destruction of muscle cells, and troponin leaks out into the bloodstream. So that's what happens when you go to the emergency room right now, is that we measure troponin, measure this marker of heart damage. Now, also too, if you get a pneumonia, you get sick, the heart can be injured through that mechanism as well. If you get very anemic, you're losing blood, or you run a marathon, you can actually cause a little bit of damage to your heart as well. So it takes a lot of skill to interpret troponin well. So we have so many markers, and sometimes the markers are too sensitive, they overcall things. And depends on the level of elevation and your clinical picture. And of course, what's also happening to you. Thanks for sharing that. Go ahead.
Yeah, so all of these signs and symptoms and these markers indicate an issue with the heart, but that might not necessarily be myocarditis. In order to determine that, your doctor is going to need to do further testing. And so some examples of the further testing that they might do include an echocardiogram or maybe a cardiovascular magnetic resonance. So start with the echocardiogram. And if you've been to clinic, you probably have had one of these done on you. And echocardiograms are essentially a way of visualizing the heart using sound waves. And so for people with myocarditis, on an echocardiogram, your physician might see dilation of the left ventricle and changes in the shape of your left ventricle. So that's different from what we would normally see in a normal heart, or they might observe abnormal motion in the walls of your heart. And we'll take a look shortly at what that's going to look like. Your physician might also order a cardiovascular magnetic resonance imaging or a cardiac CMI. And this is another way of visualizing the heart. And this uses magnetic fields and radio waves. And using this kind of imaging, your physician might see excess blood flow or volume in your heart. This is known as inflammatory hyperemia, or they might see scars or death of heart cells. And this is also, this imaging is also another way of visualizing any changes in the motion of your heart walls and also changes in the LV shape.
Yeah, so here we're just going to take a look at some echocardiograms. So on the left here, we're going to first look at one that can show similar signs to myocarditis. So this is in a patient. You can see here that from this chamber view, you can see that there is, it has a very low ejection fraction, and there was some diffuse hypokinesis. So you can see that the heart itself is not contracting as well as it necessarily should be. And you can see that as Dong mentioned, there are some changes in the shape of what the heart chamber should look like. In the right, if you compare it here, you can see that this was taken 10 weeks following that first echocardiogram, and you can see here that the ejection fraction has actually increased quite substantially to 60, with the normal range being around greater than 55. And you can see that it is contracting a lot better, and the chambers are moving a lot nicer. Dr. Curnew, did you want to, I guess, expand on that a little bit?
So Stuart, if you can just show the four chambers of the heart. Just let's look at the one on the right, the normal one right off the bat here. So you can see where that arrow is. You can see the left ventricle. That's the biggest chamber there. That's the top chamber there. Beside that, on the other side, is the right ventricle. The right ventricle is a little bit smaller than the left ventricle, and those are the main pumping chambers. So the right ventricle pumps to your lung circulation. The left ventricle pumps into all the blood vessels of your body. On the bottom there, you have the two small chambers called the atrium, the left and the right. And those small chambers just pump to the bigger, two pumps back to back on each side. And again, it's an ejection fraction is the amount of blood that's ejected every time the heart contracts. And normal, as Matthew was telling us, is over 55%. So you have a normal one on this far right. On the left, if you see that heart pumping again, you can see the whole heart is just weakened. It's just not contracting very well because there's inflammation going on in the heart. The heart's weakened, and the heart is pumping less than half strength. And so, first of all, many of the cases of myocarditis are self-limiting. This happens to be more so this is one way how your doctors can image the heart to see what's going on there. So we start off with your clinical picture, the ECG, and a more detailed look called an echocardiogram. Thanks so much. Anything else you want to add there, Matthew?
No, I think that's it. I think we can move on to some differential diagnoses.
Yeah, so these types of imaging are not only good for showing us things that are characteristic for myocarditis, but it also enables physicians to be able to tell the difference between myocarditis and other heart diseases that might present really similarly. So diseases such as stress-induced cardiomyopathy, which is a disease that causes your heart muscle to weaken because of stress, or ischemic heart disease, which is a heart disease caused by narrow arteries, they might present clinically very similarly. So you might have chest pain, and you might also have elevated markers in the blood. But using CMR and echo, your physician might be able to observe, for example, in stress-induced cardiomyopathy, different patterns in terms of the abnormal motion between stress-induced cardiomyopathy and between myocarditis. And also in stress-induced cardiomyopathy on the CMR, there is usually no scarring or inflammation, whereas in myocarditis, your physician might see that. So that's one way of telling them apart. In ischemic heart disease, there's also differences in terms of the CMR pattern, and also using a coronary angiography, which is a tool using X-ray to visualize the arteries of the heart. Your physician's able to see whether or not there's like clotting in the arteries of the heart, and then that would be able to inform them if there's ischemic heart disease. So this isn't a tool to diagnose myocarditis, but it will help differentiate if somebody has ischemic heart disease versus myocarditis.
So ischemic heart disease is blocked arteries. So what we'll do is we'll put catheters into the heart, inject dye, and take pictures under very precise X-ray equipment. And you mentioned something called tachysobus, or stress-induced cardiomyopathy, where just stress can damage the heart as well. And that's a disease that become more apparent in the last 20 years or so. Thanks for sharing that. So you can see your doctors always have a lot of work to figure this out.
Yeah, so your doctors will take all of those tests into consideration, also your clinical presentations into consideration, and possibly give you a diagnosis of clinically suspected myocarditis, clinically suspected myocarditis after looking at all of those tests. But to get a definitive diagnosis of myocarditis, you would need something called an endomyocardial biopsy. So this is a biopsy of your heart tissues. So essentially a tube is inserted into your heart and a sample of heart tissue is taken. And then this heart tissue is investigated using histology. As Anya mentioned, we have an example of this in the corner here. And essentially people in the lab would take a look at this and they would look at the immune cells here. They would look at scarring and everything going on with the cells and give a determination of whether or not you actually have myocarditis. However, this isn't recommended for everyone because it's not the case with all patients that this the undergoing endomyocardial biopsy would actually change the result of, would actually change the course of treatment. So endomyocardial biopsy is only recommended for certain populations, usually in patients with myocarditis with more severe disease, in which a definitive diagnosis might actually alter the course of treatment.
So this is rarely necessary, but certainly tools that are available when you can actually, again, if you look at that picture on the top right-hand corner, you see more inflammatory blue, purple cells in the nice pinkish myocytes. And only certain places can do that. In Hamilton, it's just the Hamilton General Hospital. It's doing in the catheterization laboratory. We don't have to do very many of those, luckily, but sometimes if this needs to be done, it can be done. Go ahead.
All right. And so just before we go on to treatment, I think we had a question from one of the patients, so I'll pass it off to Stuart.
Yeah, for you, Dr. Curnew, when a patient was asking, should patients get any special blood tests or screening beyond the normal items prior to a visit to Dr. Curnew's office?
It really depends what we're looking for. So I spend a lot of time with do preventive cardiology. So I'm looking at things like cholesterol, your blood sugar, your kidney function. But if we suspect myocarditis, the one that comes to mind is markers of inflammation, mentioned things like C-reactive protein. Obviously, markers of heart damage called troponin values, it would be nice to do, but the local labs don't do that. You have to go to the emergency room to have that done. So we need to pick the right test, and depending on the circumstances, you can start to look at the cause of why there might be inflammation. So that's sort of an individual decision what to do. But if you think you have myocarditis, the place to be is actually the emergency room, because they can actually measure those troponin values, which are quite helpful. Again, it depends on the severity. Again, having the flu, we get chest pains and things of that nature. So you have to use some common sense in all this. And we'll talk a little bit more about some of the warning signs. The warning signs are really, I really feel awful. I have a temperature. I'm having trouble breathing. I really feel sick. Then you should be in the emergency room. I have some mild symptoms. I'm doing all the things I want to. I have this sharp pain. You can call the office first and decide what to do. When in doubt, call 911. And so a lot of common sense in all this, like always. When in doubt, ask someone. The problem, if you ask certain people, they'll always send you an emergency room, and that may be the right thing under certain circumstances, but really it's something that I can't give you a firm guidance on this.
All right, so now we're just going to get into some treatment.
All right, so fortunately, as Dr. Curnew mentioned, most myocarditis cases will just resolve on their own. But you might think, so for those that don't resolve on its own, maybe we should try to resolve the inflammation using different immunological therapies. So researchers have tried using antiviral therapies. So these are therapies that target and kill the virus that causes myocarditis. And they've also tried immunosuppressive therapies. So these are therapies that restrict our immune system from doing too much harm. But unfortunately, there has been no shown efficacy of either for most types of myocarditis. There is an exception in that immunosuppressive therapies have been shown to be effective in certain subtypes of myocarditis, like, for example, giant cell myocarditis. But for the vast majority of cases, these therapies are actually ineffective. So the treatments of myocarditis are actually mostly for the treatments of the accompanying complications instead of myocarditis itself.
So if you just backtrack one slide, people are saying, well, we have these great immune suppressive antiviral therapies. They're okay, but you know what? Better not to have the disease in the first place. And I'll say this now, and I'll say this over and over again, is obviously avoiding, bacteria and viruses are good, but they're everywhere. And we now have I think it's about 8 billion or 6 billion doses of the COVID vaccine that have been given worldwide so far. Truly remarkable. These vaccines are phenomenally good, decreasing severity, transmission, certainly severity by 90%. So I don't want to get sick. I don't want to get any viruses. I want my immune system to work really quick to prevent me from getting sick. If you remember the slides with all that inflammation, I don't want to have to suppress my immune system. I want my body to protect me so I don't have to overactivate my immune system and cause destruction. I want to end the war before it gets too big, and that's what vaccines do. Remarkable. And let's hear more about the heart. Go ahead.
All right, so you might be wondering what some of those complications are that come with myocarditis that will need treating. So myocarditis can often present with, or sorry, not often, myocarditis can present with heart failure, with arrhythmias and blood clots. And I've listed some treatments here. For heart failure, these are all different kinds of treatments that you can take for heart failure, but in severe cases, there may be transplantation, heart transplants that is necessary. In the case of arrhythmias, your doctor might prescribe antiarrhythmics. In the case of blood clots, your doctor might prescribe anticoagulants. And so we've done a series of previous webinars that address these treatments in detail. And if you're interested in how they work or what criteria your doctor looks at in order before prescribing them, then you can take a look at our previous webinars for that. So you might be wondering after looking at those complications, so what is the percentage of people with myocarditis who actually develop these complications? And so for that, we can take a look at this study, which observed 443 patients with acute myocarditis in Italian hospitals. And essentially, most of the people in the study, so 73.4% of people with myocarditis presented with very little complications, but 26.6% presented with certain heart complications, such as reduced ejection fraction or ventricular arrhythmias or low cardiac output. And this is at the beginning, before any observation was done. And then these people were observed over the course of 5 years, and then they took note of the percentage of people who had death related to heart disease or heart transplant. And so in the total study population, so in this column to the right, 3% of people after 1 year experienced death due to heart complications or they had a heart transplant. And this increased to 4.1% after 5 years. And in people, so after acute myocarditis had dissipated, there was a 2.8% of people had a major adverse cardiac event. But what was really interesting was that all of these cases occurred in people who presented with myocarditis with complications. And none of the cases happened in the people who presented with myocarditis without such complications. And basically the takeaway from this observational study was that most people who have myocarditis don't end up having major cardiac concerns. And everyone who did end up having a major cardiac concern presented initially with many complications. So now that we know what physicians might do after you get your diagnosis of myocarditis, we can take a look at what patients themselves with myocarditis should be doing to manage their disease. And that is they should avoid non-steroidal anti-inflammatory drugs and also alcohol. So examples of non-steroidal anti-inflammatory drugs include ibuprofen and naproxen, and that's because these drugs, along with alcohol, they increase the severity of the disease. Also, exercise should actually be avoided for 3 to 6 months after myocarditis, and this is according to the American Heart Association recommendations. And this is because exercise actually puts a lot of load on the heart and can actually worsen myocarditis.
Hi, so I'll be talking about myocarditis and the COVID-19 vaccine, but before we get into that, I'll just be talking about a previous example of when vaccine was associated to myocarditis. So the smallpox vaccine was once, and still is to some degree today, strongly associated with myocarditis. So the unrest first came about back in the early 2000s when a report made by the military smallpox vaccination program reported 10 military personnel who showed signs of mild myocarditis within 6 to 12 days of receiving the vaccine. In light of the public discourse and multiple case studies of other cardiac complications occurring with the vaccine, the CDC placed a temporary restriction of the vaccine on those with known heart conditions. However, a review performed in 2018 of over 400,000 adult smallpox vaccinations from 1996 to 2007 found only 32 reported cases of myocarditis, of which only 18 were considered valid after critical review. So the final estimated incidence of myocarditis among vaccination was determined to be 0.24 per 100,000, which wasn't any more than the regular background rate of myocarditis at the time. So when investigating the correlation between vaccines and myocarditis, the causation is usually inferred just from the order of chronological events, and no further investigation is usually performed. Unfortunately, this is often the method of reporting used in these case studies because it is unethical to intentionally perform provocative tests on patients that could possibly directly affirm the relationship or provide any more information. So given this limitation, it is difficult to establish a definite causal relationship between vaccines and myocarditis. Next slide, please. So there are some theories, though, on how vaccines could cause myocarditis. So not specific to the COVID-19 mRNA vaccine, but in general, inflammation caused by a vaccine is most likely due to an allergic reaction. So a type of antibody called immunoglobulin E is responsible for releasing histamines, and you may have heard of antihistamines, so these are things like Claritin. Histamines are what trigger your allergic responses and can cause inflammation. You could be allergic to the actual active ingredient in the vaccine or simply its excipients, so which are the accompanying solutions that support the necessary processes. So in many vaccines, they have been cutting out such allergens like egg protein to limit these possibilities. And this is not a worry with the mRNA vaccine. Or similarly, you could display hypersensitivity to the vaccine, but through a different immune pathway, which could present delayed symptoms. And this is through T cells. And T cells are part of your immune system, and they secrete a different protein called cytokines that also cause inflammation. Next slide, please. So specifically regarding the mRNA vaccine, there are currently a few hypotheses in investigation, but none with concrete evidence. So like the allergic reaction, you could just be genetically predisposed to hypersensitivity. So these cells in your body called dendritic cells or toll-like receptor expressing cells could develop an allergic reaction when exposed to RNA. So however, this is extremely rare, and even rare with the mRNA present in the vaccine as they are nucleoside modified. So there are a plethora of other possible causes that are being investigated right now, such as molecular mimicry, testosterone levels, and different immune system receptors, and a bunch more. But because of the limited research and because there's so many contradicting evidence out there, a clear mechanism of how COVID-19 mRNA vaccine could cause myocarditis has not been established yet. Next slide, please. Okay, so now I'll just be going over some statistics on myocarditis and the COVID-19 vaccine. So in this slide, I have compared the rates of COVID-19 infection-associated myocarditis versus mRNA vaccine-associated myocarditis. So in a study investigating the prevalence of myocarditis rates among young males aged 12 to 17, which is shown to be the group with the most prevalence for myocarditis after vaccinations, it was found that those who weren't vaccinated were 6 times more likely to get myocarditis than those who did. In a CDC investigation from March 2020 to January 2021 of over 900 hospitals, it was noted that those with COVID-19 infections were 0.146% more likely to get myocarditis than those who did not. With 0.001% of infected individuals developed myocarditis, and compared this to the 0.0003% of vaccinated individuals that develop myocarditis. Next slide, please. So to identify the prevalence of vaccine-induced myocarditis and recovery, we performed a review of journal articles investigating hospitalization for myocarditis following a dose of the COVID-19 vaccine. A total of 13 primary research articles were identified. In all cases but one, symptoms were mild and the patients recovered fully and were discharged within 8 days. There were no readmissions in the total samples, and in a total size of 82, there was only one sudden death. So all this just goes to show how rare myocarditis is among vaccinations and how even scarcer serious cases of myocarditis are. Next slide, please. So in cases in which sudden deaths do occur, the findings are so different that an underlying cause is difficult to establish. So after some digging, we were able to find only 2 cases of sudden deaths. And the first case was a 22-year-old male who had symptoms occur after his first dose of the BNT162b2 mRNA vaccine. He had chest pains after 5 days and died after 7 hours. So in the autopsy, it was revealed that he had myocarditis in an isolated part of his heart. The second case was a 42-year-old male, and he received symptoms after his second dose of a different mRNA vaccine. He had chest pains after 2 weeks and died 3 days later. In his autopsy, there were no myocarditis found in an isolated part of his heart. So just to reiterate, myocarditis caused by the mRNA vaccines is extremely rare, and serious cases occur even less. And due to the variability in expression of myocarditis, the underlying cause is still unknown. Next slide.
All right, perfect. So one other thing we also wanted to discuss is GBS, acronym as GBS. And while this is not directly related to myocarditis, it is often a really kind of unknown type of effect that people are often worried about when it comes to vaccinations and infections and diseases. So we just wanted to kind of broaden your perspectives and let you know a bit more in terms of what GBS is, if it is actually associated with the vaccine, if it's associated with infection itself, just as some background, because some individuals have expressed some concerns about this as well. So this is basically a rare disorder where the body's immune system damages the nerves. There are 3 main types that are known, and it can present with a variety of symptoms, notably weakness or trouble walking, also known as unsteady gait. Some individuals may have some sort of tingling sensation in their feet or fingers. So now in the US, the prevalence is about, the incidence is about 1 to 2 cases per 100,000 people. So as you can see, and you can appreciate how rare this condition is, but of course, nonetheless serious, and want to make sure that we safeguard against it. Some things that are of note is that most people fully recover from GBS. Studies have found that 60 to 80% of people are able to walk at 6 months. So not only is it fairly rare, but of those that develop it, 60 to 80% are able to walk at 6 months. The mortality rate is around 47%, but of course, it does vary depending on study, given the small sample sizes.
So backtrack one slide there. So Guillain-Barré is a rare disorder. It usually starts in the lower extremities with tingling in the feet. And then you have this progressive weakness that starts at the feet, moves its way up. And it can move its way up all the way to the lungs. And so the people that are going to pass away from this disease is that they can't breathe because their lung muscles get affected. Again, it is a relatively uncommon disorder. The actual cause of it is unknown in the vast majority. One wonders if vaccines or viruses can cause these sorts of things. We have some association data. And the only time we will make associations if it usually occurs within 30 days of a vaccination. That would be suspicious, but certainly not confirmed. And this is actually I've seen a number of cases in my life, and most of them actually don't progress to that muscle weakness involving the diaphragm. Some need to be on respirators, but very, very rare. Most will actually recover, like you said, fully. And it's often hard to recognize at first, this tingling sensation, this weakness, and people can be often misdiagnosed as time goes on, but it's a progressive process over time. And again, that's our antennas are out at this point in time, and we think about these sorts of things. Thanks a lot. Keep sharing. Go ahead.
Right, and as Dr. Curnew mentioned, the exact cause is fairly unknown and it's under an investigation. But something that's of interest is that GBS oftentimes follows a bacterial or viral infection, including perhaps COVID-19. So specifically, it's been found that about 2/3 of people with GBS were sick with either some sort of diarrhea or respiratory illness before developing symptoms. So of course, association is not always causation, but it's interesting to note that these individuals had some sort of other underlying illness which precipitated to this. One study that we found during the pandemic, during the early days of the pandemic, so between February 28th and March 21st, 2020, they looked at 3 hospitals in northern Italy where around 1,200 patients were admitted. 5 of these patients later developed Guillain-Barré syndrome, and the investigators concluded that there may be a link perhaps between COVID-19 infection and GBS, since this rate is fairly high compared to the rate that we discussed on the previous slide. And a more recent statistic is that as of June 2021, there's been over 220 cases that have been reported. And these have been in some shape or form associated with COVID-19. Again, they can't specifically form that direct link, but they were present with COVID-19. The age range at presentation was 8 to 94 years old. So one thing of note here is that it's impacting people across a variety of age ranges. In terms of the male to female ratio, males were slightly more impacted by GBS compared to females. So that might be an interesting area for further research. So that was COVID infection. So we saw that COVID infection could perhaps lead to or be associated with Guillain-Barré syndrome. Now, many are worried that maybe I won't get COVID infection, but how about the COVID vaccine? So usually the Center for Disease Control, also known as CDC, they compare the usual rate of GBS in the population to the observed rate of GBS in vaccinated people. And if it's higher, they might become worried that it might be associated with a vaccine. So the J&J vaccine, which is a single dose vaccine mostly utilized in the US, they saw a 0.0008% of those who received this single dose vaccine developed GBS. And just to put into perspective, there has been 12.5 million doses. There were 100 cases and 1 individual passed away. Now, these are not meant to say that they were directly linked to the vaccine, but associated and reported. Now, with Moderna and Pfizer, there's been no association with GBS that has been found. And as you can see, 146 million have been fully vaccinated with both of these vaccines. And we have a fairly large sample size, and there's been no association that's been found. And even with the J&J vaccine, it's fairly low towards the base rate that we discussed a couple of slides back.
All right. So now that we've talked about a little bit about GBS and myocarditis, we just wanted to answer that big question. So is this something that we should be worried about? Should we be worried about getting the COVID-19 vaccine and getting myocarditis or GBS? Well, we decided here to compare some of the risks of myocarditis after vaccination to some other risks that are associated as well. So you can see here that the risk of myocarditis in males 16 to 29, which is amongst one of the highest prevalence rates of all patients, is actually only 1 in 9,434 cases. Meanwhile, compared to something like the yearly odds of an American to get food poisoning is 1 in 6. And if we even bring it back to COVID-19, we can see that the risk of death from COVID-19 in a patient aged 25 to 34 is 1 in 6,373, which is less than the risk of myocarditis associated with the vaccine. And obviously, with the risk of death in COVID-19 patients aged 85 and older, you can see that that's 1 in 29, which is an extremely high number relative to the risk of myocarditis. So in this case, you would say, although there may be risks associated with myocarditis, in the long run, what we're saying is those protective effects, as Dr. Curnew mentioned, of those severe COVID-19 illnesses, hospitalizations, adverse outcomes, and deaths due to COVID-19 infection can be greatly minimized by just getting the vaccine.
So one thing to remember, death is certainly very important, but the other thing too is not just death, but just illness. Anything that attacks my body and attacks my vessels causes inflammation. We know that simple things like people get pneumococcal pneumonia, common pneumonia in older people. 10% of people will die, but they also damage the heart, the blood pressure, the brain. And we know that you're never the same, and you're weak and become more frail. We know that people, especially that were hospitalized, that the UK Biobank shows that your gray matter in your brain shrinks. Your gray matter is your thinking process of your brain. So it will probably accelerate, unfortunately, Alzheimer's disease. We know that the long haulers, and you mentioned is that young people who don't get much in the way of symptoms, about somewhere between 2 to 5% have the long haul syndrome. So feeling sick and unwell after a so-called benign infection is not great, and that goes up to maybe 5% of young people. So these are serious conditions, and the two biggest diseases that have increased in mortality since COVID is obviously dying from COVID and its complications, but also heart disease. And we know that a simple flu shot, the trials called IAMI, and took people who had a heart attack, given the flu shot, decreased the chance of dying by 40% and decreased the chance of having a heart attack or cardiovascular events by about a quarter. So again, I don't want to get any foreign substance into my body that doesn't belong there. And nothing good about getting COVID, even if you're totally asymptomatic from my perspective. Food poisoning, yeah, you're probably not going to die from food poisoning, and you probably won't die from COVID, many young people, but you may have long symptoms. And the initial data from China says about a third of people that were sick with COVID still have symptoms of some form a year later. So be healthy and make yourself healthier. And one way is to prevent infections of all sorts. Go ahead there, Matthew.
Yeah, and that's actually a great point. And a lot of people might be asking, if I already had COVID-19, is being vaccinated going to help me? or is that natural immunity just going to be there? So to answer that question, have been several studies in response to that. So I'm specifically going to point out two studies. So one on the left you can see is a 2021 study, which saw 738 patients who were previously infected with COVID-19 in Kentucky, and they followed them, and they found that the patients who were unvaccinated, even after their COVID-19, were 2.34 times more likely to become reinfected with COVID-19 compared to those who had been vaccinated after their initial COVID, who had been vaccinated after their initial COVID infection. So you can see here that there is merit even in patients who've already had that natural immunity because of the infection from COVID-19. It's still beneficial to get that vaccination. And similar laboratory studies have also shown that even if you're looking at specific antibodies, which are going to be those things that are going to protect against that SARS-CoV-2 virus, as well as the variants, some laboratory studies show that getting the mRNA vaccine, even after COVID-19 infection, can increase the antibody levels up to 1,000-fold. And so these are just more reasons why it's important to be vaccinated, even if you've already experienced that COVID-19 in the past. Yeah.
So thank you for sharing that. So basically, people say, I want to trust God, I want to trust my body. Good for you. I want to trust those things too as well. And I'm going to try and make my body healthier. But it's clearly shown is that you get better immunity from the vaccine than from the disease itself. So that's important. One of the issues right now is how long do you get protection? And that's what we're learning about. So I'll remind us is that when you're first born, you have a very immature immune system. As you grow up in your teenage years until probably around the age of 20 or so, that's your peak immune system. Afterwards, it starts to decay. And it takes a big hit at the age of 50 years of age and at the age of 60 as well. That's why we start to see things like shingles come back and more infections like pneumococcal pneumonia. We see more flu illness affecting older people more so. And so it's very common for many vaccines, such as the flu, to get a shot every year because the flu mutates. So COVID does mutate and other diseases will do so as well. But also we need to strengthen our immune system. Well, I can't show this for a fact. So that's why I learned is being skinny, exercising, eating healthy diets makes your immune system stronger, but it doesn't make it strong enough to withstand the attack of many of these illnesses. So beware. And so what I did this year and last year is that I've gotten every vaccine possible that I can for myself. So something called Prevnar 13 against pneumococcal pneumonia. I got my flu shot this year, like every other year. I got my first Shingrix shot. I'm getting my second one shortly. I have my tetanus shot up to date. And so speak to your doctor, your pharmacy, and about knowing what vaccines that you may consider. So I think the best way to treat disease is to prevent it from happening in the first place. Now, you still will get COVID, or you still can get COVID if you're fully vaccinated. The severity of the disease and the chance of being really sick are lessened up to 90% at this stage. How long that immunity will last for, we're learning that in older individuals that immunity starts to waver at 6 months. We're still learning, and what I love about science, it learns and updates itself, different than opinion. So you can take the opinion if you want to. I take the opinion of people who know a lot more about science than you and I do. So I know a lot more about science than many of you do, but I turn to experts to give me advice, and so pick the right experts.
Yeah, for sure. And on that point, I just wanted to go take these last couple slides, just in case you are wanting to get your vaccine, the COVID-19 vaccine, if you haven't already gotten it, or the flu shot, which is also out now. Where you can get these are your local pharmacy locations. So for example, a Shoppers Drug Mart, a Walmart, Costco, Guardian Pharmacy, anywhere near you. They should have the flu shot, and you'll have to check online if they have a COVID shot. Your primary care physicians, again, are a great resource. Long-term care centers, if you're living in one, as well as they also still have municipal and provincial sites that are available. Particularly, you can go to the hamilton.ca or COVID-19 ontario to go book your COVID shot. And on that note, just something about the COVID-19 booster shots, which are coming out now. In general, for someone with 2 shots, the overall risk for COVID-19 infection is relatively low. So the benefit may or may not be large. We're still looking into the data. Obviously, we don't have enough at this point, but so currently it's really recommended for people who are in high risk populations or in high risk settings like healthcare workers. So you can see here the current eligible populations. So people with moderate to severe immunocompromisation, vulnerable adults living in congregate settings like long-term care homes, adults 70 years and older, healthcare workers, First Nations, as well as people who have received 2 doses of the AstraZeneca virus or the Johnson & Johnson virus. But the important thing to note is that you must be greater than 168 days since your second dose. If you go there, for example, and it's 167 days since your second dose, they will tell you to go and rebook. So that's something you should be aware of when you're trying to book your shot. And when you're there, they might ask you if you would like to get a Moderna or a Pfizer shot. And currently, there seems to be no difference between either booster shot, and there seems to be no ill effects with mixing doses. So, for example, getting a Pfizer and then going to a Moderna, or vice versa. So it's just a little note on COVID-19 boosters if as they come out in the near future. And that will conclude our presentation today. If any of you have any questions, feel free to ask us, or you can also email us at drcurnew232@gmail.com.
Well, first of all, I want to thank the team for putting this together. When I started early in clinical practice, I saw a young individual who unfortunately succumbed to myocarditis. That's the only person that I know in my career of over 30 years that unfortunately passed away from inflammation of the heart. I've seen lots of cases of myocarditis or a series of cases of inflammation or pericarditis. Most of them are very benign and go away. If you think you're having a reaction to the vaccine, usually symptoms start usually within the first few days, up to 30 days. After 30 days, it's less likely. Anything's possible in this world. In fact, the most common cause now I'm seeing of myocarditis is something called checkpoint inhibitors. These are drugs that are used in cancer right now, and so it somehow can sometimes attack the heart from medication-induced processes. It's not the vaccine; it's from therapies for treat other processes, and we're learning about that. We also know that we can suppress the inflammation with what's being called steroids, prednisone. In fact, prednisone is part of the treatment. Prednisone is a broad anti-inflammatory agent, and if you're sick and hospitalized for COVID, it actually decreases your mortality. I'm trying to decrease inflammation in general. What I learned is having a body mass index greater than 23 increases complications from infections, including COVID, other infections, being diabetic, being overweight, being hypertensive, having heart disease, having kidney problems, and a slew of other medical problems makes me more vulnerable to infections in general. So I'm in my early 60s at this point in time, so I'm being smart by getting all the appropriate vaccines. I'll repeat that. I'm in my early 60s, and once through the age of 50, your immune system starts to waver. So think about getting the shingles vaccine. Think about getting your tetanus up to date, other infectious processes that involve the lungs, or Prevnar 13 for pneumococcal pneumonia. It decreases the severity of disease by over half. And again, is that, well, vaccines are no guarantee. They make your immune system stronger, more able to recognize these threats and to your system, and do a lot more good than harm. So I thank modern day medicine for developing vaccines. We've seen on early webinars is that, the iron lung polio is an example of, and I still have a number of patients who have had polio in their lifetime. Many have required multiple surgeries and have consequence. Thank God that we have therapies for this. The vaccines aren't perfect. but they're godsend. So I want to thank the whole team for putting all this together. Any thoughts? Stuart? Any questions out there? Any of the speakers want to add anything to that? What's your thoughts, Stuart?
I have one question. We did see earlier in the presentation that in Poland from 2011 to 2019, the greatest group at risk of developing myocarditis in just the general population was between the ages of 16 to 40. Someone was asking, is there a certain age group that's most at risk of developing myocarditis if infected with the vaccine, if infected with COVID, as well as is there a certain age group that's most at risk if they get the COVID-19 vaccine?
Sure. So the people that are most at risk, why don't you find that slide if you can find that. So that we know that as you're younger, your immune system works best. So and so therefore it can be overactive. So it looks like that younger people, specifically males, more likely to have myocarditis. But I'll stress is that most of the time it's a very benign process. And there are three reasons to be vaccinated. One is to protect yourself, one is to protect others, and third is to less mutation of the disease. We're still learning. It's remarkable in a period of less than 2 years that we've gone this far with vaccinations. You're always better off if you play the odds on being vaccinated. And one of the things when I had the honor of working in a COVID ward is to try to make a difference. And making a difference, how you can make a difference is through hand washing, social isolation, still wearing your mask. It's remarkable in my office right now, and I thank Jen for being what I call our infection or COVID police. She will screen everybody or have somebody screen people. If you think you might be sick with any flu-like illness, stay home. If you think you may have COVID, get tested. But do your part to prevent spreading infection. It's not the time to let our guards down. The disease is mutated, and there's worse mutations that have doubled mortality and increased infectivity up to 5-fold. Like anything, nothing's perfect. And yes, I think right now many of us will get different infections, including COVID. And most people who get COVID don't know where they get it from because it's everywhere. It could be asymptomatic. One of my family doctor colleagues told me about an unintentional event where a unvaccinated healthcare provider went into a nursing home and all these people were fully vaccinated. And unfortunately, 8 of these older people died and 25 of these people became sick by a person who was asymptomatic spraying the vaccine. Well, the vaccine doesn't prevent total spread, it decreases the amount of spread, we believe, and we're still learning about that. So please be vigilant, keep your guard up, and be healthy, make healthy behaviors. And being outside is 35 times more likely to have less spreading of virus compared to being inside. So with this, people being inside, you can see some countries are reacting to when one person gets it, the whole house gets isolated. We currently have a policy in our office, and that's an evolution. If you've traveled outside of Canada, we prefer you not to come to the office for 2 weeks afterwards at this point in time as a precaution to prevent illness from others. And I think if you do travel, spend some time being isolated and don't be afraid to test. Many pharmacists, including the Shoppers Drug Mart in our building here, can test people asymptomatic by a rapid test or the traditional swab as well. So so I'm worried about this winter time, about people letting their guard down. Don't let your guard down, and get properly vaccinated for all the diseases that you can think about. Yes, younger people have less chance of getting sick from COVID, but they still have a very high chance of spreading the disease to other people as well. I don't know how you feel if you're a 20-year-old individual who unfortunately gave the disease to your grandpa that was vaccinated and passed away, and how you might react to that, because that's certainly a possibility. So you have to think about how you respond in society at this point in time. And I'm not here to preach, but just so to inform is that we have a remarkable series of very effective and very safe vaccines. You've seen the downside in this video here, and they're relatively infrequent. Unfortunately, over 27,000 Canadians have died from COVID. You can see that parts of the provinces that have the hardest impact is with the lowest vaccination rates. And now we're seeing a resurgence of some people being vaccinated whose immune system has started to waver. And many people have a very weak immune system. You're getting cancer therapy, you're on immunosuppressants at this point in time, you will not respond well to the vaccine. And so we want to protect those people, and we want to protect everybody. Simple question, long answer, but the simple answer is get vaccinated for as many diseases as you possibly can. Any other thoughts for anybody in the audience here? I'm very proud of our team, and I'm really at times frustrated with people not wanting to protect others by not wanting to wear a mask properly. If you wear a mask, you wear it over your nose. And we know that a surgical mask that are 2 or 3 layers is much better than a cloth mask. We know that N95 mask is much better than the other masks as well. And the reason to wear a mask, number one, is to protect other people first. N95 mask is to protect yourself, and they do work. And simple things like washing your hands and avoiding people that are sick are important. So be respectful of that and be respectful of numbers. The more people around, and there are times when Jen will say, we have to get people out of the office now, and we will get people out of the office now. And we're not trying to be mean or whatever. We're just trying to be safe. And I thank Jen for keeping us safe. Any other questions or thoughts from anybody? I'll give Stuart the last word.
Well, thank you. I just wanted to say that for today's webinar, my takeaway at least is obviously research is always evolving. As of November 2021, this is all of the information that we are able to share with you today. We just wanted to, emphasize that, the virus, the reason why it's so important to get vaccinated is because the virus is multiplying, it's evolving, it's changing, it's mutating, and with more mutations, obviously there's a greater chance of myocarditis potentially becoming more prevalent in populations that get infected. So today we wanted to present the data on comparing the risk of getting myocarditis with the vaccines and those without the vaccines. Based on the available data, the risk of developing myocarditis is about 1/3 as common as it is in populations that are unvaccinated. So as Dr. Curnew said, it's a little bit about playing the numbers. While there may be some risk in the long run, the risk of developing cardiovascular related complications, dying in hospital is far less in populations that get immunized with 2 shots of the COVID-19 vaccine. So that's why we really wanted to present the data for you to make an informed decision for yourself. We know that there are many causes of myocarditis, not exclusive to COVID-19 vaccines. Not exclusive to COVID-19, but we also know that for example, bacteria, viruses, pathogens, all these things can also cause it. So stay safe, stay protected, wash your hands, socially distance from people. If you're able to get the flu shot, try to get it as soon as you can. Dr. Curnew presented a very interesting study. The IAMI study suggests that in populations that recently had a heart attack, the risk of having all-cause death or having a future heart attack is almost half as likely in populations that get the flu shot shortly after having their heart attack. And so that suggests that flu shots may become a part of standardized care moving forward after someone does have a heart attack. It's all interesting research, and it's all important for you to know. And so we wanted to break it down for you in a way that we hope was easy for you to understand. If you do have any questions, of course, you're always more than welcome to email us. We presented the email at the end of the presentation, but again, if you'd like to send us a message, it's drcurnew232@gmail.com, and we'll get back to you with all your questions. That's it for me. Dr. Curnew?
Well, thank you so much. I can't think of very many scenarios where if you look at by the pure numbers game, you're always better getting vaccinated unless you have a true anaphylactic reaction to the vaccine. Which is something that is treatable for the vast majority of people. So it's hard for me to understand from a scientific perspective why people don't want to get vaccinated to protect them and other people. So that's my stance based on the experts around me. But glad to talk to you individually if you have any concerns. So if you have any concerns about any vaccine, send us call the clinic or send an email to drcurnew@232gmail.com, and we'll talk about you individually as well. I'm surprised that many people are still hesitant. So, I'm always struck by discussions. I love to hear people's perspective on that. So I encourage people to, if they have any thoughts, just to put it into the chat, bring it up. Always willing to explore new possibilities. And thank you so much for the team. I can bid everybody good night.